Hello, everyone. My name is Robert Hamilton, co-founder and chief scientific officer of NovaSignal, and welcome you to the next installment of the NovaSignal webinar series. And I'm very excited for today's conversation on the missing link in the development of a comprehensive stroke program by Dr. Yadlapati and Tina Villanfresca today, talking about comprehensive stroke center and looking at cryptogenic stroke. Today, we'll start with Dr. Yadlapati. He obtained his undergraduate degree from the University of Illinois and received his medical degree from Rush Medical College. From there, he went off to UCLA and studied both pediatrics and internal medicine. After that, he went in to his interventional cardiology fellowship at the University of Chicago. Dr. Yadlapati has a number of publications and grants where he specifically focuses on novel therapeutic procedures in patients with complex structural heart diseases. Tina has joined us from Sharp Memorial Hospital as well, who oversees cardiology, vascular, and EEG services. Her role as an administrator and clinician gives her the opportunity to onboard dynamic diagnostic solutions for a variety of patient needs. Tina is a registered nurse with a background in acute and ambulatory health, patient health, healthcare operations, and team management. With that, I'll turn it over to Dr. Yadlapati for today's conversation. Thank you very much.
Thanks, Robert. So it's an honor to be here, more for the educational premise that we're going to talk about. This has been a kind of the new frontier of structural heart disease that was once forgotten, and luckily there's been more and more data coming out of the missing link about comprehensive stroke program. And it's not just the cardiology, put a PFO device in and call it a day. It's more to try to figure out what is the best care for patients going forward. And I think the issue that we've had is the fragmentation of care throughout the population, especially in the United States. So what I'm going to talk about today is our agenda is going to be talking about cryptogenic stroke, just going over the basics. And I really want to understand pathophysiology more than anything else. And I think that's really important because that helps guide us what direction these trade winds are going. We're also going to talk about transcranial Doppler, of course, and the reason why I think that is the missing link, which we've seen throughout the entire population. And then we're going to talk about the heart-brain approach. And then Tina, who's been exemplary and also a pivotal person in our development as a program, is talking about the hospital administrative pathways and how you could also develop that very similar to ours. So the best, I will tell you, is the worst, which is the best care that we can provide is sometimes the worst. I know that sounds like an oxymoron, but it's true in the sense that if you look at fragmented stroke care, we think we're giving good care, but that's not the case. So if you step back and look at most hospitals, we see that they get good neuroimaging. They come in, acute stroke care is exceptional for especially stroke centers around the hospital, such as ourselves. And there's a lot of people coming in that basically can help alleviate the potential, ramifications of strokes, TPA, interventional, neurointerventional, and so forth. That, of course, is the part that a lot of hospitals have kind of pivoted towards. But the vast majority, they come in, the stroke's already occurred, they're outside the window, and basically they say, okay, what was the cause of the stroke? And if you look at it conventionally, the guidelines show that you get a TTE, or a transthoracic echocardiogram, with a bubble study. And essentially, if that's negative, 92 to 95% of the hospitals in the country will send them home. And essentially, they say, sorry, you had a stroke. And the reason why I have personally made this into kind of my area of experience, more so to say, is that I really feel for these patients. And I've had, as our population continues to grow with the patient population and cohorts that we're talking about, and I also brought up a lot of the things I've learned, good and bad, over when I was in Denver, which is a huge stroke center. And I basically said, wow, the one thing that everything that I've seen so far has in common is that patients are just not getting good care. And we have a system that has a big cavitation model and a fee-for-service model as well too. But the capitation model, even though we have exemplary primary care, they get sent to primary care. The primary care then sends to neurology. Neurology says, we're too busy. We can't see these patients. There's nothing we can do. It's 21 days of Plavix, aspirin indefinitely, a statin, and then you kind of just, wash your hands with this. And then the patients kind of said, I'm really scared. That's a horrible, horrible event. I have PTSD from it. I never want to deal with this again. What can I do? And most people just say, I'm sorry. Hopefully it doesn't happen again. Exercise, eat well, take the medications. That's about it. And we'll talk about that is not the proper care that a lot of patients should receive. So if you look at the 2020 AAN recommendations, which are updated from 2016, this is kind of just a basic premise of where a lot of hospitals are going towards when it comes to what age of population and you're going to really intervene upon. The PFO closure they talked about is usually you're going to see this 18 to 60 group with PFO and no alternative stroke risk. And we'll talk about certain people, why they are more prevalent in regards to higher risk for recurrence, and more importantly, what anatomical features are more important comparatively just having a PFO in a binary fashion. The shared decision-making process is the most important. I know that's kind of one of these things that we conventionally say, oh, we should always do it, but I spend time talking with my patients about every potential, pathway, and it's ultimately up to them and me. I'm there as an educational guide, guidance counselor is what I always tell people, and they can ultimately make a decision. Some people say, you know what, I'm 57, I've had one stroke. Hopefully, I'm not going to have another one. Leave me alone. There are other people that, I have a 22-year-old that comes in and says, I'm so scared to have another event. What can I do to help prevent this? And those are the conversations you need to have. The basics of cryptogenic stroke. And I think this next couple slides, I want to really talk about the pathophysiology more than anything else. So if you look at a cryptogenic stroke, it's a kind of a similar word as idiopathic. It's a doctor's term, of course, that we have no idea what causes this. Sorry. And 88% of strokes are what we call ischemic strokes. Now, ischemic, as you remember, is a blood clot that can travel, or some kind of material that basically prevents blood flow, hair down the drain, I tell my patients, versus hemorrhagic, as you guys know, is a bleeding event. So if you take those 88% of strokes, which are ischemic, 40% of those have a stroke of unknown cause. So they basically are, say, cryptogenic. It's nice when there is someone that has an ICA, or a lesion, and the stroke was in that territory. They get a fix from a vascular surgeon. We're done. But that doesn't happen all the time. And if you look at those patients that have cryptogenic strokes, now, if you do this next subset of patients, 40% of those, up to 60%, some studies show that the frequency of PFO among those cryptogenic strokes, is 40% of those have a prevalence of a PFO. So what is a PFO? Let's start there. And I think this is the nomenclature that many physicians do not understand. So a PFO is a persistent flap-like opening. We talk about that. And what I tell patients is that you have an atrium, septum primum, and a secundum. And it's kind of essentially like two walls, okay? And what it is not a true hole. If you look at it a cross-sectional looking straight at it, the septum, you're not going to see a big hole. Instead, you'll see a flap of tissue on top of a flap of tissue. And it's a true tunnel. And that's important to understand. So in utero, if you guys remember embryologic physiology, you have a right to left shunt. And that is because you have the umbilical cord is connected. And essentially, that shunt physiology is important. There's a lot of embryological components here that people don't realize. If you look at the right atrium, it's one of those atriums that are parts of the heart that people just don't care about too much, but I think it's fascinating because you have, when we look at the IVC right over here, the eustachian valve is the remnant that actually directs flow from the IVC into the PFO. And these are things that we'll talk about as we get on, but the anatomical closure is basically looking at, should we close this and this with an umbrella device, which is relatively easy procedure. But 25% of the population has these PFOs. So if you look at it, visual learner, and that's kind of the way it is, I want you to go look at this. These embryological charts are very, very, very informative. So if you look at it in the cross-sectional view, like I said, you don't see a big hole, but if you look at it, it's a flap over flap. Essentially what you have is this septum secundum, which basically emanates from the top ridge and comes down, and the preeminent comes up here. So if you think about it, like I said, you have this fossa ovalis, but what happens is you're going to have tissue that grows. And how does that tissue grow? It's actually, again, fascinating. Embryologically, what happens is that when you take your first breath in, you increase your PVR, and then that PVR, or pulmonary venous resistance, basically causes this pathway of wonderful events that basically closes this fossa ovalis. So what this does is essentially allows closure, but it gives you 1 out of every 4 people that closure does not occur properly. And I tell patients is, simplicity wise, that the glue between the preeminent and the secundum don't come together. So it's a tunnel. And that's really important to understand. I love this review paper that came out in AJCBD about 2 years ago, but they basically broke down kind of the picture schematically of this is the tunnel. And if you look at it, this is the difficulty of why TTE and TE are very difficult if you don't know what you're evaluating for, is trying to visualize this tunnel that comes over. So the mechanism is stroke. So the clear plumbing physiology, you need high to low pressure for flow to occur, just like a toilet, just like a drain. And if you look at the pressure in the right atrium compared to in the left atrium, you basically know the left atrial pressure is usually higher. And this is the caveat that needs to be engraved, in every brain of every physician, is that you need to have a right atrial pressure movement that will increase somehow and overcome left atrial pressure. And that is the mechanism where these blood clots, or whatever mechanism or whatever etiology you're talking about, crosses from the right to the left side. So how does it occur? Okay, let's talk about some examples. Pulmonary hypertension, elevated right-sided pressures. You have volume overload, which you don't see. But here's the other thing, wind instruments. I have a patient that was doing a Frida. If you guys remember, those are the sucking instruments when your kid has snot in their noses and you're sucking the snot. I think it's barbaric, but guess what? I did it when my kids were young too. And he valsalvaed on one of the initial sucky events. And guess what happened? He had a massive stroke afterwards. So, you're looking at what can cause elevated right sided pressure. And other things are decompression sickness, which we'll talk about, in high altitude flying, and even coughing, as we talked about. So a rope score, simple terminology that we've been installing in all the rooms. And more importantly, we're getting more recognition. And the rope score is quite honestly simplistic. It doesn't really have too much of, wow, this is groundbreaking work, but it gives you an idea of what's happening. I want you to look at this. A rope score says the younger you are when you have a stroke and no other risk factors, the likelihood of you having a PFO is higher, and the PFO is more contributable to the stroke. Simple. So if you think about it, do the rope score, because that gives you a little bit more of indication, hey, this is right. And usually it's like if you have a 25-year-old that comes in and has no other risk factors, their risk, and they had some cortical infarct imaging, something simple, you'll see that their score is going to be 10. And that is basically, if you look at the 9 to 10 group on the rope score, if you have the number of patients, look at this. You're looking at more than 50% of patients with a score of 9 to 10 that has a prevalence of a PFO, and the attributable fraction of PFO actually increases as well too. So what that means is that as you get higher rope score, the likelihood of having a PFO is higher, and that PFO is more pathologic. So this is the slide I love showing cardiologists, because this is I think the disconnect. Every PFO is not the same. So what it is that if you look at the size of the PFO, there's some conventional things that look at, and these are a lot from the RESPECT and REDUCE trials, but basically you're looking at, greater than 30 bubbles. And we'll talk about the caveats of that. But the size of the PFO is actually very important. I'll explain that. If you have a long tunnel length greater than 8 millimeters, so if you look at over here and you look at the tunnel length, compare to short tunnel length, and then you have a long tunnel length over here. Over here is the long tunnel length greater than 8 millimeters. They think that the stasis of blood in that tunnel is a predisposing factor for micro blood clots. So that's important. So you're not getting a cardioembolic phenomenon that traditionally people think about, which is basically, hey, big clot comes in, it doesn't go into the pulmonary circuitry. Instead, it goes into what? It goes in the left side. But instead, there's some information that's coming out that even a long tunnel length can be something susceptible for formation in situ of clot. And what's interesting is that those are the patients that see a lot more TIAs, minor clots, because it's a small tunnel. But again, pathophysiology beyond what we conventionally think. The atrial septal aneurysm is the most important thing, and that is the excursion that you see over here. Now, there's different guidelines on what you want to do, but in summary, I do an A plus B length of, which is right here, A plus B, of more than 1.5 centimeters. Everyone's a little bit different, but the reason why this is important is if you look at the primum and secundum side by side, I always talk about it as a C-shaped septum. And just like a sail, you are taking separation of tissue between the primum and secundum away from each other. That's really important because as you increase right atrial pressure, that separation occurs more often and more significantly. You have a thick septum secundum, prominent eustachian ridge. This is what's fascinating, again, for embryologically. If you look at it, if you have a right atrium, and essentially what happens is you have these eustachian valve, it's directing flow essentially right into that PFO. So when you have a prominent eustachian valve, that is a bad side that basically you are going to get falsely negative bubble studies because it prevents the bubbles from actually getting up into that area. I'll explain that. And then what's happening is that you will actually see that prominent eustachian ridge, if there is a clot, it can actually be pushed into that direction as well too. All right. I'll be very quick on the subgroup analysis, but this is going to be RESPECT, but this is where the data is coming from. The reducing RESPECT trial, and John Carroll has done an excellent job with this as well too, explaining this, is that you have this atrial septal aneurysm. You can look at PFO closure, and this is where the design has come in. If you look at shunt size, one of the things I want to bring up is anticoagulant. Yes, it's not, it still crosses, but one of the things that I want you to understand is that there's slight improvement with anticoagulation compared to antiplatelet. And that's really important because our conventional medical therapies, and I have tons of slides in this, which we're not going to talk about right now, about what is the best medical regimen. Antiplatelets in general are very, very futile in preventing strokes, but that's still conventional therapy. So these things I want to bring up just as an idea, an illustration of why we do what we do. So patient evaluation, PFO closure. We talked about this. You get a hypercoagulable panel, head and neck, CT, MRI. If you do genetic testing, you get an EKG, maybe some extended monitoring. But the whole point is you get a bubble study, and the bubble study is positive. That's pretty easy, but that doesn't happen most of the time. So the whole point of this is saying we are missing this transcranial Doppler, which I think should be standard of care. So why? If you look at this, and I'll give you good examples, you have an echo with a bubble study. If you look at the sensitivity of a TTE, it is 43 to 58%. So I just gave you a ballpark figure of 55% based upon the average sum data. But you're looking at a TTE only. This is basically the standard of care. You are missing essentially half the patients. That's just mind-blowing to me. You have a TEE. Now, this is greater than 90%. Here's the problem. If you look at the studies, these studies for TEE are people who are specifically looking at PFOs. So what that means is at the end of the day, there is a large variability on how good practitioners are also, even with that, because the subjective nature of a TEE on doing it properly. So what a TCD does, and we'll talk about that, is the sensitivity and specificity is great, but the sensitivity is what we really want. We really want sensitivity to rule out the possibility of a shunt. So, give you an example of this patient I just saw. So what happened is, this is the patient that comes in, and one of the things I want to look at is massive stroke, young patient. Look at it, there's a huge atrial septal aneurysm. So there it tells you that there's something possibly pathologic here. So they do a bubble study, a limited bubble, and the kid sent to me because she had a PPO and she wants to see me for a second opinion, but that was it. I looked at her primary note, they basically said stroke, Plavix is gone, aspirin's on, statin's on, that's about it. So she had a pretty large right MCA stroke, and I was like, wow, this is a little bit different. So what can I do? I was just in the room by myself, and I got the echo tech. I was like, can we just do this right now? We can put a bubble in, and you can see just by me pushing on the belly and making her really Valsalva, you can see bubbles cross pretty clearly here. So this tells you that there's a lot of subjective error if you don't do Valsalva right, if you're not injecting. And one of the things I always tell patients is, one, my recommendations with the bubble study is, if you're going to do it right. Get a large bore IV, have them flush right afterwards. Make sure they do a good Valsalva. So that's one. Now, on a TEE, I never do TEEs in the afternoon. I never try to do them as an inpatient because they're dehydrated. They're going through all these medication changes, and it's not worth it. And I also give them a 2-liter bolus before we start the TE in the morning. And the reason why is I've had so many false negative TEs in the past when people do them inpatient. So what is it? Why a transcranial Doppler? That tells you, again, the sensitivity is low. TCD or transcranial Doppler has a higher sensitivity, much, much higher. I always say if it's a negative TCD, okay, and the caveat was that you do a TCD right. The problem before is that you had to get a specific tech that does TCDs, and it was very limited. Now, what we're seeing is we haven't been using TCDs because not many people are trained in them. And it's very difficult. So when we start looking at what TCDs should we use, we kept on going through every one of them. In our group, what's interesting in our group is we're not, we're salaried. So everything that we do, when it comes to building up a population of, PFO patients doesn't provide more for us. When it comes to salary, it literally is, what can we do that will give us the best overall outcomes for our patients? And we really thought about that very closely. Instead of saying, we can do a TCD that might be able to find more patients, possibly if we have a really good tech. I know one of the things that we looked at was, why not make it autonomous? And that's kind of where, Robert and Anuja and all these people from NovaSignal came down, and we were kind of blown away by the potential possibility of doing an autonomous. What that means is taking that subjectivity out, that potential bias, and basically make these patients kind of binary, yes or no. And now we're going back to the binary standpoint of, do they have a shunt or not? And we can talk about this in general, but basically, I will tell you from a conventional aspect, our vascular tech has no issues about doing these, and more importantly, it was really simple, and it actually integrates into our EHR really nicely as well too. What that means is that the signals are good, and Tina will go over a little bit of why we chose this as well too. So let's go through a couple cases, and then we're going to talk about kind of the pathway, how we started our program. So we have a 32-year-old documented stroke. For simplicity, I will tell you that they went for a second opinion, got another TEE done. Got their first TEE done at an outside hospital, which was definitely the right thing to do. They did a TTE bubble study, was negative. She wanted a second opinion. The doctor did it. I looked at the TEE, good image quality, but once again, one bubble crossing, and they said, we're done. So what I'll tell you is that I did a TEE, and first thing you see is the atrial septal aneurysm. And look at the bubble study first. And this is the conventional aspect of people get into 120 degrees in the TEE. And what you do is you say, wow, I'm done. And a lot of people will leave the TEE there. And what I want you to show you is that, look at the negative contrast. That is negative contrast, that black. That means there is pressure built on from the left side, preventing the right side from going or beating the left side. So what I do is I always go and I push down people's bellies significantly. I give them extra fluids, And I do bacteriostatic saline as well too. And now look at me, I push on the belly and I go to a different view, and you can actually see all the bubbles crossing over there as well too. So if you go into different views, I do 5 bubbles for almost every patient. That's just me. But once again, people call me the bubble czar, but I will inject, and I will find something if I can't find it, because it'll help me risk stratify. Other things, anatomical features beside the atrial septal aneurysm, you see a short tunnel leg thing over here. And this is something important. And one of the things that'll help risk stratify you on your discussion with your patients, do you think this is pathologic or not? So Valsalva is important. Watch the Valsalva, okay? If you do a negative bubble, it can be done, but Valsalva, and the reason why you want to do that is like a sail. You want that to open up the sail and basically allow the bubbles to cross. And I'll tell you, if you do it properly, you don't want to over medicate these patients as well too. And what's interesting is here, you can see the prominent crystal tumoralis as well too. Small things that we'll talk about later if we have time. Another one, 36-year-old female, stroke, negative bubble. Look at the bubble study. If you look at the inferior aspect of this bubble study, the tech doesn't know where to really spend most of the time. Yes, you're looking over here, but they spend a lot of time getting the LV access here. What you're looking at the end of the day is you can see the atrial septal aneurysm here with a significant left-sided pressure elevation. Now, what I want you to look at here is this is the bubbles, this is the TCD. This is how simplistic it is to read it. So when you're looking at it and you're injecting as well too, you're looking at the RMCA and the LMCA, and you'll hear it increase in power. See them crossing right over. That's it. But what I'm trying to say is that we have a radiologist read it because they're in-house 24/7. And I will tell you that alone is something that you guys can talk about. You don't need vascular study reading qualities to be able to read these. What that means is that you don't need to be certified in that degree. So it's something that you guys can talk about on who's going to be able to do that. Now, if you look at the TE on the same patient, I did this, and this is the 120V. You can see those bubbles crossing, and we put in it was actually a 7mm conduit defect, and basically we put in a 25mm amplastor device. So why do I believe in these in this process is basically to identify patients where I think the PFO closure will be beneficial. If you look at respect, reduce, and close, even defense PFO, small study, but very, very good in regards to overall their overall data is that if you look at it and specifically look at respect and reduce, you're looking at a significant relative risk reduction of stroke. And that's important. And these effective closures, if you look at it, it's greater than a certain amount of bubbles. Respect was about 10 bubbles, and then reduce was 25 bubbles. We don't even look at bubble studies anymore post, and I'll explain that as well too. But essentially, you're reducing the risk of stroke. And if you look at this, look at the stroke risk rate, when you look at it, these are huge relative risks. If you look at the absolute risk, yes, I know you're talking about a couple percentage, but a couple of percentage are those patients that you're missing. And even closed data, you're looking at 6 to 0%, 5 to 1%, but basically you're looking at a 6 to 2% risk reduction. And that's kind of what I tell my patients at the end of the day. This Kaplan-Meier curve was great in regarding to look at the trial closure data, but one of the things I want to look at is, look, antiplatelet regimen alone, mixed medical therapy, you'll see that, freedom from recurrent stroke is still not that great comparatively to anticoagulation and PFO closure. So if a patient is on anticoagulation already, unless they have had multiple strokes on anticoagulation, I will not close them. Okay, so I'm going to go to the next part, which is the brains of our operation, which is Tina. Tina's going to go over kind of the hospital administrative aspects of why we're doing this, kind of our data, and we're relatively new. We've started only in October in regards to this stroke program. We keep on building every month, and I'll explain that as well too. But Tina, do you want to go on and talk a little bit about why we chose what we did and kind of go from there?
Sure thing. Thank you, Dr. Yadlapati. So yes, I'm in the unique position of ensuring that my staff and my doctors have the right tools to ensure our patients by turn have the best care. So Dr. Yadlapati came to me probably almost 2 years ago and shared with me his background in PFO closures. And we decided that we need some really good diagnostic tools if we're going to enter the cryptogenic stroke space. So we set out to find a TCD machine with the capabilities for bubble study. Our hospital has a rocky history with transcranial Doppler studies. My vascular techs, however, were really engaged and excited when I said, hey, we can do more than just scanning for DVTs all day. I'm lucky to have a really great team who was excited to explore the path with me. They were really excited to go shopping for a new machine. So we entertained demonstrations on 3 different TCD machines. Initially, in all transparency, we thought that NovaGuide 2 was going to be out of our price range. However, the consensus from my technicians was that the more traditional TCD machines still maintain that technical challenge of getting through those tricky temporal windows. So we talked a lot internally about the robotic capability that NovaGuide 2 lends, and we wanted to use the automation to our advantage. So we considered, other TCD tests, such as emboli monitoring and vasospasms, future applications for such an awesome technology. And together we decided to jump into the new technology instead of settling for what we came to think of eventually as kind of the more standard devices. Next slide, Dr. Yadlapati. So automation is one of the NovaGuide 2's most valuable features. And after having used the machine now for 7 months, it really does set the usability aside from the competitors. As Dr. Yadlapati touched on in a previous slide, the robotic acquisition algorithm, it really does yield to a reduction of manual technologist scanning, and it promotes successful signal capture. In manual scanning, many techs will give up after a few minutes. I have one that said he'll only try for 90 seconds. And then when they can't locate a signal by hand, that confidence level kind of just drops. The NovaGuide 2's algorithms show purposeful progress. If you see it in person, it's really, really fun to watch. The machine will identify any signal that it can find. It'll mark that spot by a placeholder, if you will. And if that's the only spot that the robot can find, the tech, all they have to do is touch the screen to go back to that signal location. Now, that automation is just not something that a tech can do or replicate by sweeping their wrist. Another really unique feature of NovaGuide or of NovaSignal is the NovaGuide View cloud application. I don't know about your PAC systems, but our PAC system does not play sound. Sorry, I have an overhead announcement just a second. Surgery. My apologies for that. I have a code speaker in my office. Our PAC system does not play sound. So the NovaGuide View cloud-based application, it stores your patient studies. Your users can see and hear and interpret on this portal. And as Dr. Yadlapati showed in another slide, and I'll show again in a couple of slides, it really does make a difference when you interpret these studies. It makes it much more easy to really hear those hits. So NovaSignal was instrumental also on helping me compile the justification for our hospital's purchase of NovaGuide 2. NovaSignal, their sales team pulled together CMS data and illustrated modest projections for revenue. And I was able to earn my chief operating officer's buy-in by incorporating growth and revenue in the PFO closure space. Further, as I mentioned before, my team was considerate of future case use applications like OR cases and ICU monitoring or rule outs in the emergency room. I mean, you could literally park one of these everywhere and teach practically anybody how to sit a patient in a cradle and run the algorithm. We're proud to be the only lab in the greater San Diego area performing TCD bubble studies. This gives our hospital an edge as a referral center for outpatient TCD testing, and in turn lends the potential for a stronger reimbursement platform. Next slide, Dr. Yadlapati. All right, so Nova Signal has a dynamic group of experts behind the build and maintenance of their modalities and applications. They worked extremely well with my hospital's IT team to ensure that we implemented workflows that catered to our systems and our processes, not, they weren't trying to cram any kind of workflow onto us. We were able to integrate what we're already doing and use the platform of NovaGuide View and result our tests very easily. So Nova Signal met with our super users, myself, our IT analysts weekly or more to ensure all details and concerns were addressed prior to our go live. Now, I will have to say that our go live was one of the most smooth go lives I've ever gone through in my 13 years in leadership and administrative roles in diagnostic spaces. Nova Signal had clinicians on site and analysts on standby for the first 2 weeks of our using NovaGuide 2. Their mantra is, "We'll be here until you tell us to leave." They made sure that we were really, really comfortable and confident using the device. We got lots of training materials, both the physicians who are now interpreting these studies for us and the technologists, and those materials were invaluable. For those technologists that are dialed in, yes, they gave us CEUs, and that was a super win for my techs. Physician and technologist engagement was very, very important, and I will say that the Nova Signal staff had been really patient with us, very, very supportive. Next slide. So yeah, so this is a patient, a 54-year-old male who initially had a negative transthoracic echo bubble study. I bring up this clip because later on a TEE, he was found to have a grade 3, a small tunnel PFO. Now without, in the older, more standard approach, without the transcranial Doppler, we may not have done a TEE on this patient, but I bring in the slide, Dr. Yadlapati played one earlier. I'm going to play it again just so that you can see and hear the deflections. It makes it really, really obvious for the interpreter. There's a Valsalva. All right, you can stop that clip. So I will go over just really quickly what we've done. Dr. Yadlapati kind of touched on that we're growing every month, and that's definitely true. These are our TCD numbers at my hospital for the last 7 months. Keep in mind, again, that we're still learning the utility of transcranial Doppler, and that the standard of care for so many years has been transthoracic echo with bubble for stroke workup. Now, most of these orders were the result of a negative bubble study by TTE in patients with strong risk factors for PFO. So in the last 7 months, we had done more TCD studies than our hospital had done in the 5 years prior to us installing NovaGuide 2. So total studies were 57, and as you can see, 29 of those were positive by TCD, notably 22 of which were negative by TTE, transthoracic echo. Now, I will have to point out that there were 3 negative TCD studies that were positive by transthoracic echo, and these were due to inadequate temporal windows, either bilaterally or unilaterally, so it was difficult to acquire those. And then so if you'll go to the next slide, we'll talk a little bit about the inpatient workflows. And the reason that this is important is because our hospital, we haven't moved to say that, one test is better than the other or anything like that. If you look at this slide, we bring this slide into our presentation to show, as Dr. Yadlapati kind of touched on earlier, the many tests that we put a patient through when we're evaluating them for cryptogenic stroke. For our purposes here, we emphasize the addition of transcranial Doppler bubble studies. It's an extremely valuable tool for this patient population. And then that last slide, Dr. Yadlapati. So this is a very busy slide, and I did this for our ordering providers here at our hospital. I don't want to discourage them from ordering a test that they feel is necessary. What we really wanted to do was offer them another diagnostic tool. So in both of these workflows, so we really start with age, and then we is there an echo bubble? If there's not, go ahead and do one. But if you do a transcranial Doppler and it's positive, you don't need an echo with bubble. You can just do a complete echo instead. And that's it for my slides. I'll hand it back to Dr. Yadlapati, who's got more to talk about with our physician engagement piece.
So thank you, Tina. Again, Tina was instrumental. You need someone to really push the envelope on the administrative side to be able to get this taken care of. And I think, having allies to be able to look at the overall goal. For me, the overall goal was how to take better care of these patients. And the hospital's overall goal, yes, they're going to say that that is their main impetus, but I think it's dollars and cents, is that this is a very lucrative aspect where you get younger patients with PPO and so forth. And what's happening is the hospital side is also going to be very happy about that at the end of the day, which personally in my job, I don't care too much about. But what this order sets as well too is with Epic, we have Allscripts, Cerner, and Epic, and I'll tell you that it's relatively simple to create a new order set that will actually be able to do drop down for this. So what we're doing is we're basically getting a basic TTE with bubble with mostly anyone. If it's negative, they are going to get a TCD. What we're trying to facilitate is, remember, I told you TCDs, just like TEs, are not going to be as great right when you're about to right when you're in the hospital NPO all the time. So what we're trying to figure out is, should we be doing these when we leave and creating an outpatient clinic where we do all the TCDs once a month? And that's what we're aiming for ultimately. And then the TCDs with positive bubble studies will then refer to cardiology automatically, where consultation, and then you can talk to the patient about shared decision-making about the TE. So that is kind of where we're going. We're going at 65 rather than 60 because we don't think a 60-year-old and a 61-year-old have any difference. And like I said, it's really up to the clinician about the clinical judgment. The clinical judgment's the biggest thing. If you have a smoker, diabetic, and there's a high chance for AFib, we put everyone also, before we close, on a 14 to 28-day e-patch monitor as well too, as part of our algorithm. But in general, what I'm trying to say is use your clinical judgment before doing anything at the end of the day. So the last thing I want to touch on really quickly is what we've done over in Denver and then over here is we're in the process of really facilitating a heart-brain team approach. So we are creating a clinic where both the neurologist and the cardiologist see the patient together. And some people, from a logistical standpoint, when it comes to billing and so forth, will have kind of sequential visits with a conversation outside. There's a lot of different things that we can do, but either way, what we are trying to do is we have now talked to our neurology colleagues, and we are basically creating a workflow where these patients who are discharged from the hospital with a negative bubble study are able to see and get reevaluated by neurology and cardiology to make sure the workup is thorough. And that's kind of where we're going for. And the reason why it's a complementary basis and collaboration, where the neurologists are so vital in talking about the stroke etiology, neuroimaging. They can look at the CT right there with you. And then the cardiologist can look at the imaging, look at, hey, look at the 14-day e-patch, look at the cardiac manifestations, look at the left atrium and the echocardiograms that are dilated, and then also say, hey, is this a feasible PFO for closure and so forth? And what this does is it really puts emphasis on shared decision-making where the neurologist, the cardiologist, and more importantly, the patient all agree that this should be closed, and that should be it. But basically, a stroke workup should be thorough. We basically do make sure everyone gets all imaging. They get a 14 to 28 day E-patch. We do 14-day hypercoagulable testing. TTE we talked about, and then of course the transcranial if the TTE is negative. And then personally, this is just me, I do a TE on every patient, even with the transcranial Doppler, to absolutely make sure that this should be closed. And it gives you an anatomical variation about what the specifics of the PFO is, and more importantly, they can have more of a guided and educated decision with the patient on should I close this or not. So in conclusion, look at cryptogenic strokes as not just idiopathic, but look at them as what potential etiology is occurring for this patient. Look for these high-risk PFO patients. Recurrent strokes is another big one. If there are recurrent strokes, really look into them as well too. I just had a patient, 3 strokes, 2 TIAs, 5 TTEs, 5 bubble studies, 2 TEs, all negative, TCD positive, and we basically closed his PFO, and he's been doing great since. So there's all these little caveats that we can talk to, and he was on Eliquis, and was then on Coumadin and aspirin. He hated it. So there's a lot of different things at the end of the day. Consideration of TCD, look for a test that you guys are comfortable doing. Like I said, we are on the mindset of getting as much ambiguity and subjectivity away from the provider or the technician as possible, and even the provider, and basically make this into a binary statement. And that's what autonomous TCD does. Collaborate with the hospital, neurology, and really make a heart team approach when it comes to the brain and the heart. They're basically working together. When you look at different venues, they have their unique interests and, more importantly, their strengths about when a neurologist will be able to provide and a cardiologist will provide. But at the end of the day, you can improve these outpatient pathways that which are lacking. On that, I'm going to end it right there, and I'll leave it up to Robert to figure out, what else we are going to do after this.
Thank you very much for the presentation today. There are a number of questions that have come up, so we'll go through that. Starting with what is the recommended patient pathway when the TTE bubble study reports a trivial minimal number of bubbles or a mild with the Valsalva maneuver only? So I think it's in that in-between case where you have a minimal TTE bubble study being positive.
So that's a great question, because again, those are the patients that get lost and they say, hey, this is a small, on patients with a mildly, let's call it mildly positive, just like the TE, you might be mildly positive, but actually missing a larger hole. So what I always tell these patients is if it's positive, you don't need the TCD. If you want to get a TCD, you can do a Spencer, grade and get, it's probably going to be a 3 to 5. But it's really going to be, should we go to the TE to look at the anatomical configuration? Because that's what the thing that TCD doesn't provide. And what it does then is going to be able to tell, hey, anatomically, this looks like a high risk pathologic variant. And you're going to be able to do a good bubble study to be able to see how many bubbles are really crossing. I'll tell you, so many times, even a mildly positive bubble study is not accurate, just like a negative bubble study as well, too.
Next question in that same vein is, do you have a plan for TCD bubble studies as a follow-up exams following PFO closure as part of your normal workup?
So we are very ice heavy in ours in regards to, I do a T on every patient before. Afterwards, I do not do anything but a TTE with color. I'll explain that. What I've realized is that I do a bubble study at the time of closure to make sure that there's no significant bubbles closing at the time of with intracardiac echo. But I send my patients home the same day. I do it with intracardiac echo. And in the last 2 years, I think we've had 90 patients, 89 have gone home the same day. So for follow-up, we do not do a transcranial Doppler, and we do not do a TE unless there's a recurrent stroke. And all the 90 patients that we've closed recently, no one's had a recurrent stroke. So I can't tell you about that situation, but for the most part, I don't think it's necessary to get another TCD, and I don't think it's necessary to do a TE, also because of the invasive nature of the TE, many patients don't like doing those.
Makes sense. Another question regarding TCD outpatient. I'm trying to understand why your TCD outpatient clinic plan is only for once a month. Can your current volumes of your outpatient TTE bubble studies be done in one day a month?
So basically, you're 100% right. We are still growing. So when I was at Denver, it was a much larger population. We would not be able to just do everything in 1 month. The reason why is insurance. So we have to make sure we get adequate approval from insurance, which is going to be one of the big caveats that you're going to get right now with TCD. So that's a limitation. So if we see that, we'll try to do them in-house. But a lot of times for loss of follow-up and also to be complete, a lot of times we're doing these in-house still. What we're trying to determine is that if the patient is sent for this cardio heart clinic with neurology colleagues as well too, our philosophy would be to get the TCDs all done in one day. And the reason why it's a workflow issue with the vascular tech, because a vascular tech is so important and so vital to this. If they can do multiple of these, and the good thing about the autonomous with NovaSignal is that it's pretty quick. So you can do, a significant portion of these in an entire day without any issues at all. So Tina can probably attest to how many we can think. This is a postulate of what we're deriving and thinking about. But Tina, what do you think?
Yeah, so for the first 4 months of our outpatient clinic, we picked 1 day per month. That was really because we had anticipated, having a number of patients. And in the event that I had a technician that needed some support from NovaSignal, we wanted to get that on the calendar of our NovaSignal clinical specialist, and he's been very instrumental in helping us through all of our studies, and he's given us really good feedback on how to acquire the best signals. We are moving in the next couple of months to being able to do 1 TCD outpatient per day to open up flexibility for our outpatient scheduling. So it wasn't that, we wanted to limit necessarily the access or anything. We wanted to be sure that our staff had the support of the clinical people from NovaSignal to help us in the event we got stuck on a busy TCD day.
A few more questions. What is the best way to determine PFO tunnel length?
PFO tunnel has to be by TE. So what I always do is that if you look at it, everyone's anatomy is a little bit different. I go and I scan the septum basically from 0 degrees all the way to 160 degrees and even to 180, which is essentially a reverse 0 degree view. And you're basically looking at that probably the 30 to 70 degree mark where you're going to see the tunnel length more. And that's because you're going to be more in the short axis. That's where you see the tunnel much more. And what I do on a bubble study, and this is what I always do, is I clock and counterclock in those views to actually see the bubbles crossing. So that's a little technique that I use, and you'll actually see most of my bubbles crossing instead of just seeing it kind of in hindsight in the back or in the aorta.
Question about reading. Who do you have currently reading the TCDs, the TCD studies?
Great question. So, like I said, NovaSignal has made it very simplified, and I'm not a very smart man, but I'll tell you that I could read them. So what it is that at the end of the day, we have our radiologist do it. And the reason why is it collaborates with a neurologist and our radiologist really nicely to make a more of a simplified approach that is everyone's on board. And to have their expertise, because they're always on 24/7, to be able to read that makes sense. And otherwise, the cardiologists are able to read it. There's neurologists that are able to read it as well too. So you can choose who you want it to read at the end of the day. The radiologists are the easiest because there's always someone reading 24/7. And also the infrastructure of PACS was really nice where they were able to upload and be able to get that information pretty simplistically.
A question about workflow, it seems. Have you had any interest in using TCD as your sole right to left shunt screen, reserving cardiac testing, whether TEE or ICE, for positive TCDs? If not, what is the reservation?
So the reservation first is that, remember, the standard of care still has been TTE, okay? So that you need to look at a TTE because it gives a lot of information on left atrial side, valvular disease, and other kind of potential cardioembolic phenomenons, right ventricular strain for potential pulmonary hypertension, or pulmonary embolism. We don't know yet these numbers. It's a really good sensitive marker, but it doesn't give specificity. So what you want to do is take the whole picture, get all the information, and then use the TCD as your adjunct in this subgroup of patients. You could theoretically do a TCD on everyone. That potentially would cause a lot more patient procedures that might be unnecessary because it doesn't lend to the specificity rather than just sensitivity. So what I use the TCD is really as a negative marker. It's sensitive. That's what you shouldn't be using more of a specificity marker saying, I think we got a PFO. So what I do is I try not to do ICE until we actually are doing the procedure. And I don't do a TE unless I have enough information where I think I can close it and I think it's going to be useful. So it's really trying to limit a superfluous amount of tests that might not be beneficial to the patient.
I guess related to that question, maybe more specifically about extracardiac shunts, is this something that you see often? From your perspective or your clinical experience?
Yeah. So one of the things that extracardiac shunts are something that we are seeing late bubbles, especially on TE, but even on when you're looking at an echo TTE, what they'll say is sometimes they'll say bubbles after 7 cycles. Consider extracardiac shunt, but sometimes that is a false reading, and that's what's really important. That's when our first question was about a mildly positive bubble study. You don't really know that's truly mildly positive or not unless you do something more provocative, such as ICE or TE. So, in general, you could get extracardiac shunts, but remember, this test is about sensitivity. So, if it's negative, there is probably no shunt whatsoever, and that's really important here for the TCD.
Well, with that, I think we had all the questions answered. I wanted to thank you again for the fabulous presentation today on both the clinical and the administrative aspects of comprehensive stroke centers and looking at cryptogenic stroke pathways.
Thanks for having me. And like I said, if there's anything else, feel free to reach out to me and I'll answer any questions and direct it to Tina as well too. She can also help you as well.
Yeah. Thank you very much.